Anatomy for Emergency Medicine. My name's Dr. Andy Neal. I help run the website emergencymedicine.ireland.com. Where I do a fair bit of writing and blogging on general emergency medicine topics and literature. I currently work as a lecturer in anatomy in Trinity College Dublin, but really I'm an emergency doctor at heart. I just seem to have been temporarily waylaid along the way. One of the nice things about anatomy is that not a great deal has changed. Last time I checked, the appendix was still on the right side, the heart's still on the left side. It's not what you would call a rapidly advancing field of research. So why anatomy then? Why spend any time doing this? Just because that knowledge hasn't changed doesn't mean that this stuff still isn't important. What I'm trying to do with these videos is to try to have something that's very clinically focused, simplified to a level someone like me can deal with. And really the things that you need to know about the injuries and the pathology you see in the emergency department. I really want you to understand a little bit more about what it is you're actually diagnosing. So we're going to start with a favourite. We'll start with the cervical spine. We see a lot of cervical spine injuries, but like a lot of orthopedic injuries, it's not just the bones that define the injury, but the soft tissues as well, the things that we can't see on the x-ray. Okay, so a few basics to start with. Here we have on the left a typical cervical vertebra, okay, and on the right we have our standard lateral neck x-ray. What are we looking at when we look at the x-ray? Okay, well the first bit, the obvious bit, is the vertebral body. Okay, a big chunky bit sitting anteriorly corresponds to the vertebral body that we see here in the cervical vertebra. Next bit we come to see is the pedicles. Now this will cross over a wee bit further to cover the body as well, but the pedicles consist of the articular facets. Okay, so these are the facet joints where one vertebra articulates with the one above and below. After our pedicles we have the lamina. Okay, the lamina would correspond to this part here in the superior view. The lamina is a piece of bone covering over the spinal cord and the spinal canal. And then last but not least we have the spinous process jutting out at the back. So that's what we're looking at when we're looking at a plain film x-ray. Okay, let's start with a little bit of a case, almost a good idea. Here we have an obese man in his 60s with some alcohol on board. He's had a rollover RTA returning from a long international trip, and he's been ejected from his sleigh. He's had a hyperextension neck injury, no neurological findings, but complaining of a lot of pain. And we can see here, hopefully you can see, we have a nice little peg fracture. Okay, fracture right through the base of the peg being the bit that juts out of C2. And you can see it in the lateral view here as well. The peg would normally be situated running vertically. Here it's angled quite dramatically forwards. So we have a peg fracture. So what now's gone on here? What's happened? We need to talk a little bit about the ligaments of the C-spine to explain this type of injury. We need to start really with the atlas. The atlas is the C1 vertebra, the very top vertebra of the cervical spine. C2 with the peg sticking out of it is the vertebra sitting below that. Probably the most important thing we need to know about for this is the transverse ligament of the axis. This ligament here that's running across the peg, okay, it sits like a seat belt, that's the way I kind of think of it, holding the dens process the peg of C2 in place so that the atlas can't translate forward on the axis. Okay, you can think about the rule of thirds when you're thinking about the spinal canal at this level. Okay, a third of it is going to be taken up by the peg and the ligament, a third of it's going to be taken up by the spinal cord, and the other third is free for a bit of movement, some cerebrospinal fluid and the meninges that run over it. This transverse ligament, okay, this is a view where the lamina spinous processes have been removed. We're now looking into the spinal canal, okay. The transverse ligament of the atlas is part of the cruciate ligament complex. This would be the transverse ligament. There is a vertical component to it as well. The apical ligament would be attached onto the dens process as well. That needs to be held distinct from the alar ligaments that are running obliquely, attaching onto the occiput. So we have these really important, really strong ligaments that are all involved in holding the atlas axis and the occiput together. Okay, and these are the things that can kind of get injured in a peg fracture. So what does any of this have to do with peg fractures? Okay, we'll stop these little videos and we'll come to these in a second. There are three types of peg fractures. Like a lot of orthopedic injuries, someone's come up with a classification system. Type 1 tends to be the tip of the peg, usually caused by an apical ligament avulsion. Type 2 is through the base of the peg. Type 3 would involve extension into the lateral masses. We'll not worry too much for now about what we do with all these things. But there is a grading system 1 to 3. It does guide us a little bit in what we're going to do. When you look at CT scans, let's try and see those ligaments that we just talked about. Whereabouts are these ligaments going to be found in the CT scan, and how on earth are they related to peg fractures? Okay, this is our standard, what would be our peg view in a plane film. We've got the peg sticking up between the two lateral masses of C2. If we go a little bit further backwards in the CT, at this point, this is where you'd find the transverse ligament of the axis, running transversely between the two lateral masses of the atlas, okay, between here and here, okay, acting like a seatbelt, holding the peg, if we come forwards, holding the peg in place. Sagittal view, let's find our midline, okay, there's our midline, there's our peg sticking up from C2, okay, there's our atlas on top, okay, anterior and posterior arches. The cruciate ligament complex, the transverse ligament, would be found just here, okay, it's stopping forward movement of the atlas and the occiput, okay, it's there like a little seat belt to stop it moving forward and causing any impingement on the spinal cord. So this is what we have, this is what Dear Santa has. He has an injury to his peg, okay, broken through the base of it here, and it's caused some anterior displacement of the atlas and the axis. The big thing to get across here is that the transverse ligament of the axis, or the atlas, is still intact, okay. This transverse ligament has caused pressure on the peg and has caused it to snap off. Quite often in these cases, the ligament itself is still intact even though the bone is broken. What we tend to get, you can get problems like this. Let's have a wee look. Okay, so this is someone who has a fracture of the peg. So your peg sticks up through here, okay, we have a fracture through the base of it. This is atlas, this is axis. There's gross instability in this fluoroscopy video, okay, showing that the atlas and axis moves dramatically forward on the axis. So the transverse ligament is still intact, it's still holding the peg in place, but the bone itself, the peg, is broken, okay. So that's something we need to be aware of when we look at peg fractures. This is the type of problem that can result in it that can be grossly unstable, certainly if the transverse ligament is still intact. Okay, the other problem that we see this in sometimes is rheumatoid atlantoaxial subluxation. People with rheumatoid arthritis, the synovial joint between the peg and the atlas can become inflamed. Eventually you get all the granulation tissue, you get the pannus that you get with rheumatoid arthritis. That can cause a lot of swelling in the joint. That can cause the peg and the atlas to be subluxed on each other, causing changes in an x-ray we would see. Worst case scenario, the transverse ligament itself can actually be ruptured just from the pressure and the displacement that we have within that joint, and then we can have gross instability of the upper part of the cervical spine. Looking at the MRI here, this is our spinal cord medulla just passing through the foramen magnum, passing through C1 and C2. You can imagine if you have a whole bunch of rheumatoid muck in here that you're going to get some neurological symptoms as well. So something to look out for in people with severe rheumatoid disease. Okay, flexion extension views. There's a whole debate about whether or not these are of any use. They're probably not of any use. Where I was doing the initial part of my training, we certainly used them occasionally. What on earth are we looking for in a flexion extension view? Why are we moving these people's potentially unstable necks about? What we're looking for is ligamentous instability. Okay, we're looking particularly for the longitudinal ligaments here. This is separate from the transverse ligament we just mentioned. We're looking for instability in the longitudinal ligaments. So where on earth do we find these? Okay, the longitudinal ligaments run, unsurprisingly, longitudinally in the cervical spine, which is three main ones. Okay, there's others, but we'll start right with three main ones. We have an anterior longitudinal ligament running anterior the vertebral bodies, a posterior longitudinal ligament running posterior the vertebral bodies, and the third would be the ligamentum flavum. Okay, ligamentum flavum you'll probably remember is the one that you often feel the pop as your needle goes through when you're doing an LP or an epidural or whatever else. Let's have a look at the anterior longitudinal ligament to start with. On the left we have an anterior view here, okay, in the median part, in the midline. Anteriorly we have this long, strong ligament running the entire length of the cervical spine, and runs down through the thoracic spine as well, all the way down to the sacrum. We have the anterior longitudinal ligament. It's attached very tightly at the discs and at the lips of the vertebral body, just on either side of that. It tends to be attached very loosely, if at all, actually, on the bodies. But this is where you're going to find it most tightly attached, just along where the discs are. So altogether we have this anterior longitudinal ligament we've already mentioned. Posterior to the vertebral bodies we have the posterior longitudinal ligament, and then between the lamina, as we talked about earlier, we have the ligamentum flava, or ligamentum flavum. Okay, it's a very elastic, it allows for a lot of stretch in the ligamentum flava. Again, why on earth these things are important, we'll come to that in a wee second. This is just where we're going to find the three ligaments again on the x-ray. Okay, the reason this is important, you've probably all heard of the three-column model of spinal injury. This was largely developed by a guy called Denis. He seems to be a French man back in the 80s. It seems to be a model for understanding spinal injuries that has stayed to this day. it divides the spinal column into 3 columns. Okay, we have an anterior, middle, and posterior column. Injury to more than one of those columns usually implies instability and might direct you towards actually managing the injury slightly differently. The anterior column tends to be made up of the anterior 2/3 of the vertebral bodies, okay, and the very important anterior longitudinal ligament that runs through there. The middle column consists of the posterior third of the vertebral bodies, the posterior longitudinal ligament, okay. And the posterior column is going to be made up then of pedicles, lamina, and ligamentum flavum, and the other ligaments that are involved in that. So that's your 3 columns of spinal injury. Looking at this X-ray on the right, let's try and apply this information that we have here. You can obviously see a fracture. This is what's known as a reflection teardrop fracture. It would be obvious enough to see the fracture, but what you have to think about, and what I want you to think about, is the other things that are injured in this. There's also, may well be, disruption of the anterior longitudinal ligament, but also disruption of the posterior longitudinal ligament. That means that the anterior and the middle columns are both involved. Okay, so this is more likely to be an unstable injury, often something that may need fixed or certainly immobilized, that's for sure. Okay, that's it for now. I want to keep these things brief. I know the attention span of emergency physicians, you're not going to last very long with this. If you have ideas, thoughts, corrections, send me an email. If you have ideas or topics, things you want looked at anatomically for emergency medicine, let me know. Send me an email, okay? Once again, thank you for watching.